All right, well, good afternoon to everybody here and at home that are joining us for our state chest. This is our first state chest of the season. And it's a very special state chest because we're also joined by all our pulmonary and critical care medicine applicants. So today is our first day of interviews for the interview season. So we're really excited to welcome you guys. I met a few of you this morning. We're really thrilled that you're here and that you're joining us for this really interesting talk. I get the distinct pleasure of introducing the speaker today, which is Dr. Vruksha Cabral, who is going to talk to us about no voice, big decisions, conservatorship in medicine. So a couple of words about Vruksha. So Vruksha joined us from Temple, where she was already a very accomplished resident. She had an interest in pulmonary embolism and pulmonary vascular disease, so she had already worked in several different research projects regarding thrombectomy and high intermediate risk PE. Then she came here and she excelled clinically and has been doing very well from a scholarly productivity perspective. She's had a number of different interests. So for example, during her fellowship here, Vruksha has taken a particular interest in ICU outcomes or interactions in the ICU between our families, our caregivers, and our team in general. And some of the highlights of the projects that Vruksha has been involved in include now a qualitative survey to assess training variation in interventional pulmonology that has been part of our more recent interest, the history, impact, and legality and conservatorship in the ICU, which you'll talk about today, and then illuminating outcomes, which is related to the impact of light exposure and ICU mortality. So Vruksha has had an overall interest in critical care outcomes that is part of what we're going to discuss here today. More recently, though, apart from everything that she has done, she thought that wasn't enough work for her. So she decided she was going to go and seek an advanced diagnostic bronchoscopy fellowship at BI, where she spent a few months learning highly advanced endoscopic procedures. So fortunately, she's still with us, at least for a little longer. So it is my great pleasure to introduce Vruksha to share her talk with us on no voice, big decisions, conservatorship in medicine. Thank you, Vruksha.
Awesome. Thank you everyone for joining me on my talk today on conservatorship. This has been something that I've been interested in since I was a med student at UConn. I saw this when I was in my ICU rotation as a med student and was very frustrated by certain scenarios. Then I went and did some training in Pennsylvania where I didn't notice as much conservatorship issues. And then I came back as a fellow and that thought process of what's going on here in Connecticut started brewing again. So I wanted to take this opportunity during grand rounds to dive in a little bit deeper. I was told this is a mandatory slide, so I'm not sure if there's anything I need to do here, but there's CME code if anybody needs it. It's also down here, 53877. All right, so we're gonna just dive right into the objectives. 3 key objectives. We're gonna talk about some historical key cases that have really defined withdrawal of care and conservatorship in medicine. We're also going to talk about some cases at a federal level and some laws at state level, and also some hospital policies that we should be aware of when we're making complex decisions for patients who are incapacitated and often unrepresented. At the end, we're going to take all of this knowledge and we're going to apply to some complex clinical scenarios in the hopes that you have learned something new and can figure out some complex situations together. When I decided to do this talk, my goal was to talk to all the experts so you don't have to, and then present the data to you. I am by no means an expert in this topic. So people I had reached out to was our ethics department. I worked closely with our Yale legal department, and I worked closely with expert lawyers in Connecticut as well who do this on a daily basis. I also tried to get probate court involved as well. Unfortunately, they're very busy and very hard to reach. So that was one person or one group I wasn't able to get involved, but I think we have pretty good expert involvement for this talk. So why does medical conservatorship matter in the ICU? Approximately 70% of our ICU patients will lack capacity to some extent. When you break that down further, about 43% lack capacity to make any decisions, and then 28% need some joint help from their surrogate decision maker. And then there's this last group of 10% of the patients who lack capacity and have no surrogate decision maker. And those are really going to be the focus of this talk today. So these are the incapacitated and unrepresented patients. And that's 10%, and that's a statistic from 2020. I imagine that that number will continue to rise and continues to rise to this day. So in 2017, the approximate number of unrepresented patients who were unable to make their own decisions was approximately 70,000. Nowadays, that estimate is to be around 330,000. And as we have more patients who are baby boomers who continue to grow and live longer and longer, potentially have dementia downstream, this number will continue to rise. And I think this is very important to kind of realize that this is going to become an issue and is already becoming an issue. So we have to really establish appropriateness on how we want to go about taking care of them. So here's a case example of a patient that I'm sure we've all witnessed at some point in our critical care experience. 82-year-old, end-stage kidney disease, end-stage heart disease, and now with advanced lung cancer, who has multi-organ system failure, is on increasing pressure requirement. There's no advance directives to guide our decision-making, and social work has not found any family members or friends to help us understand what the patient's wishes would be. In this ICU scenario, there will be certain situations that we're going to have to make decisions, such as how do I place a central line and what legal backing do I have to do that? Tracheostomy and PEG placement if they continue to remain intubated. Can I switch to a do not resuscitate code status? If I do, what is my legal backing to do that? And how do I withdraw care? And once again, what are my rights? What are my patient's rights? And so my goal is by the end of this talk, you can go through these scenarios that are fairly common and have some legal backing to understand what is appropriate and what is not. So before we do that, we're going to dive into some key cases in history that have defined withdrawal of care. Not to age anybody in the audience, but you might have lived through some of these cases because they're not that old. So in 1970s, one of the first cases was Karen Quinlan. This was in the state of New Jersey. This was a 22-year-old who ended up in a vegetative state after accidentally overdosing on sedatives and alcohol. Her parents, seen in the middle here, worked very hard to talk to fight the right to make decisions on her behalf. The concept of guardianship, conservatorship, surrogate decision-making had not been established in the country yet. So when they initially went to their local court in New Jersey, they were actually denied the right to withdraw care. There was concern that that is seen as homicidal. They continued to fight this case and went up to the highest court in New Jersey, at which point they actually deemed that it's not unlawful to withdraw care. It actually is a way to allow a natural death. So you're not causing death, you're allowing natural death. And so they were finally able to withdraw care for their daughter. This was the first time we started talking about right to die and also guardianship and surrogate decision-making. But once again, this was just at the state level. Next case is Barber versus Superior Court. So this case happened in California, and it really addressed the concept of futility. Mr. Hurst was a patient who went for an ileostomy closure. Unfortunately, this was complicated by cardiac arrest and complicated by further severe brain damage and deemed to have almost no chance of recovery. The family members, given all the information they were given, said, we would like to withdraw care and would like him to be off of ventilator support. The physicians taking care of him took him off of ventilator support. He continued to breathe for many days afterwards, at which point the physicians deemed it to be inappropriate to continue IV hydration and oral nutrition. So they stopped that as well. The patient died a day later after all of that was removed. The state of California sued the physicians for inappropriate care, stating that they weren't sure if you are able to withdraw nutrition and if that's appropriate or not. So this is the first time we started talking about futility. In this case, when the case went up to the California state court, the physicians argued that this is not just withdrawal of care, this is futile. There was absolutely very little chance this patient would survive and have meaningful life. So it is inappropriate to continue IV nutrition, IV hydration and oral nutrition. They were actually able to win this court case. I put these newspaper articles from New York Times. It's actually, I realize, very hard to see. Oh, no, you can see it. But it's doctors accused of a starving comatose patient, and then two coast doctors accused of mercy killing. They're really not great titles and do not present physicians in a great light when they were just doing something that was seen to be futile. But regardless, they won the case, and that the concept of futility became something that many states started integrating into their laws. The last case is Cruzen versus Missouri. So we already established by many different states that you are should be allowed to withdraw care. In this case, 25-year-old Nancy Cruzen had a motor vehicle accident and ended up in a vegetative state. Her family members said that she told them personally that she would never have wanted to live like this. And so they requested that she be withdrawn from ventilator support. The hospital actually refused their request and said that in the state of Missouri, you need to have clear and concise evidence in order to withdraw care. And to the hospital, just her saying to her loved ones that she would not have wanted this was not clear and concise. So unlike the other cases, this one actually went all the way to the US Supreme Court. The family continued to fight for the right to withdraw care. The US Supreme Court actually sided with Missouri and said, while you have constitutional right to withdraw care, the states get to decide what evidentiary standards they want to set for when they will allow that. And so in this case, Missouri wanted clear and concise evidence, and just having a verbal conversation with the patient prior to that was not enough for them. So this actually is the first start of the concept of advance directives. Let's write things down in legal writing, so this way your wishes can actually be held accountable. So unfortunately, as you can see this tombstone here, she had the motor vehicle accident in 1983, and then she was at peace in 1990. She was forced to stay on a ventilator for 7 years when she finally died of sepsis. And then this book is a book that her long-term attorney wrote, and it's The Many Deaths of Nancy Cruzen, The Long Goodbye. And he was always an advocate for appropriate end-of-life care. So in all of these cases we talked about, patients are incapacitated, but they all had a surrogate decision maker speaking on their behalf. The majority of this talk will be for incapacitated without surrogate decision maker. And that really makes it a little bit more confusing in most states. So the now what varies from state to state. As you can see from previous cases, it was really the states that were deciding what to do in those cases. And that continues to be the case today. There is no federal law to decide what you can and cannot set, what rules you can and cannot set in individual states. So the only thing the federal law states is that you need to, according to the Patient Self-Determination Act, which is the 1990 Act PSDA, when a patient arrives to your hospital, you have to ask, do you have an advance directive? And you have to inform them that they have the right to refuse care. That's the one criteria. The second criteria is that whatever you decide as a state, there has to be some leniency where it protects the constitutional right to withdraw care. And then the third rule that the federal government sets is that there are special populations such as prisoners, infants, and federally funded facilities where they get more involved and set better standards. But for most part, there really is no guidance on what states should be doing. So let's talk a little bit about Connecticut, and we're going to spend a lot of time on this slide because I think it's very important. So if you have an incapacitated patient come into your ICU, they have an advance directive, then we're going to go with this pathway. That's the easiest pathway, right? They've already written down their wishes. There's a healthcare proxy to speak on their behalf. Everything is legally correct. If they don't have an advance directive, then what often happens in our ICU is we say, oh, who's the next of kin? Who's the loved one? Is it the spouse? Is it the adult children? And we have a pathway we use as a hospital to guide our next of kin. But actually, in the state of Connecticut, there is no legal backing for what we do. When we reach out to the next of kin, that is not a healthcare proxy written in paper by the patient. So in Connecticut, what we do almost on everyday basis in the ICU is actually there's no legal law to allow for such a thing. So let's say they don't have a loved one. So you are now incapacitated and you are unrepresented. Then we break it down into 3 different criteria of what kind of decisions that need to be made. If they're non-urgent decisions, the state of Connecticut requests that we get a conservator involved. So that's right off the bat, court-appointed conservatorship. That's what is recommended by the state and legally correct. If it's an emergency decision, almost all 50 states across the country have this presumed consent. So it's assuming that the patient would have wanted any kind of treatment that saves their limb or life, you are allowed to do. So for example, in that first case we talked about, we asked if that 82-year-old should get a trach and peg. That's a non-urgent decision. In the state of Connecticut, you would need to reach out to a court-appointed conservatorship if you want to do it legally. In the state of Connecticut, if you wanted to do the central line for the increasing pressors, you can assume the emergency presumed consent, and you can use that for your backing to do the central line. So let's talk about the last 2 scenarios in that initial case we talked about, changing code status to do not resuscitate or withdrawal of care. That's when you're going to come down to this last set of part of the slide. So in the state of Connecticut, there is a rule called Removal of Life Support Systems Act. This allows one physician alone to make a decision to withdraw care. I say that very strongly because that's actually very unique. I went through lots of different states, and that kind of power to put on one physician alone is very unique to Connecticut. In most places, they require 2 physicians or interdisciplinary team or court-appointed guardianship. But in state of Connecticut, while we have such vague and ambiguity in so many other ways, when it comes to withdrawal of care, we allow one physician to make that decision. I think there seems to be some kind of disconnect here. That one physician, I will say there's 3 important rules that physician has to follow in order to withdraw care appropriately. 1 is that you have to assume this is in the patient's best judgment. 2, you have to say that the patient is terminally ill. And 3, you've done your best to find a next of kin or the patient's best wishes. You've taken into consideration everything you can find about the patient. If you do those 3 things, then you as a physician alone can withdraw care, change their code status to do not resuscitate, and you cannot be held liable as long as you document that. At Yale specifically, we want to go one step ahead. And so we take that Connecticut law and we just add a second physician to it. So I'm sure many physicians here have done the 2 physician code status changes or 2 physician withdrawal of care. And that's more of a Yale policy. Under the treatment option policy, we have added that we would just like a second physician to also confirm that that's appropriate. So that's the Connecticut law and practice patterns. As you can see, I feel very strong that there is a lot of room to grow and fix things. There's a lot of ambiguity, especially with the loved ones, not having a healthcare proxy, but having loved ones, they should have a right to speak up. I also think that there needs to be other ways to have decision-making that's not just going straight to court-appointed conservatorship. And I will get into why I feel that strongly about that. So I went through lots of different other states, but for the sake of time, we're going to focus on New York, our neighboring state, because I think of all the states I found, they actually had the best practice patterns. So here, we're going to go through the same pathway. Advanced directives, of course, you're going to follow that. If they don't have advanced directives, then New York has this amazing act that came out in 2017 called Family Healthcare and Decisions Act. Here, it allows for a hierarchical decision maker. So while we do this similarly to New York, we don't actually have a law to legally back us. In New York, there is a specific law that allows you as physicians to say you're the next of kin, and so you can make the decision even though you're not written down on a piece of paper and deemed healthcare proxy. This law has a lot of really complex cases and nuances that it clarifies. So for example, if your next of kin is somebody who may be, there's some concern for elder abuse or financial incentive, or you just don't think they have capacity, it specifically says that you as a provider, if you can document why you're concerned, you can skip over that kin and go to the next person. So it actually has very clear and concise laws. So if you don't have a loved one, so now you're incapacitated without a surrogate decision maker, then we have the 3 different algorithms we had previously. Non-urgent decisions, unlike Connecticut, which tells you go straight to the court-appointed conservatorship, New York laws actually allow all the decisions to be made within the institution. So for non-urgent decisions, simple things such as, should I start this patient on metoprolol, some medications, things like that, things that you wouldn't necessarily need consent for on a normal basis. You can do that as a primary attending with your own best judgment, and you don't need a conservator to back you up. For things that are non-urgent, such as procedures, for example, tracheostomy, peg tube placement, you need 2 physicians within the institution to agree that that's appropriate for this patient or inappropriate. Once you document that, you may proceed. Or, as always, you can always go through court-appointed conservator. Emergency decisions, once again, like I said, all 50 states have the presumed consent, and so you would do the same thing for that. For withdrawal of care, Connecticut allowed 1 physician to make that decision on their own. New York requests that it's an interdisciplinary hospital ethics team that does that decision making. And I think that's better. I don't want to be the one held liable to make a decision on someone's life. I think we remove bias by having an interdisciplinary team of experts make those decisions. So I love that New York actually integrates that into it as well. This specific act talks about different scenarios that are outside of the hospital as well. So if you're in an extended care facility, who's going to be doing these things? It actually breaks it down within that too, and it gives some power to the medical director at the facility to make certain decisions as well. So it really tries to offload a lot of the workload from going to the probate court to decide all of these things. And it, as I mentioned, goes through a lot of unique situations, and it's very clear and concise, and yet within 29 pages. And I, as not a lawyer, was able to read it and understand it. So all the states I reviewed had clear immunity for withdrawal of care when basic principles applied. As I had mentioned before, you have to say this is in the best medical judgment, patient is terminally ill, and you've done your best to figure out what their wishes would be. If you do those 3 things, Connecticut is very crystal clear that you cannot be held liable as the provider. And that's, I think, really important. But this is just for withdrawal of care. My frustration lies in what to do in those patients where it's not withdrawal of care, but rather inappropriate care. And in those cases, there really is no Connecticut legal laws to back you. And so that's why we often feel nervous about making those decisions. And we go to the only legal pathway we know, which is the court-appointed conservatorship. So this is a fantastic paper that came out in 2020 at ATS. I'm sure you recognize some names here like Mark Siegel, but it's a really great paper, and it talks about existing policies, both at the legal level and medical level. So it talks about different societies and what do they recommend on who should be making withdrawal of care decisions. And as you can see, both legal task force and medical task force, no one really suggests it should be 1 physician, such as Connecticut suggests it can be. Also, only 1 society, the American College of Physicians, suggested we should be going to court-appointed guardian to make those decisions. Almost everyone unanimously agrees there should be some multidisciplinary team that makes these decisions, and I tend to agree for that. So here we are. We're talking about conservatorship, and that seems to be the topic that we're going to be going in. So let's talk about what conservatorship is. So in state of Connecticut, probate court has all jurisdiction over a conservatorship. Conservators can be involuntary, which is what we see most often, but they can also be voluntary conservators. And I'll give a case later on what an example of a voluntary conservatorship looks like. They can be court-appointed attorneys, or it's a family member who would like to legally make decisions for the loved one. And of course, they could be of the person, which means they're the healthcare proxy, they take care of all the healthcare matters. Or they can be of the estate, which means they manage the patient's finances, or they can be both. So it's very important when we're talking to the conservator to confirm, are you the conservator of the person, which is what matters the most to us in the ICU. So like I had given you many cases at a federal level and state level about surrogate decision-making and withdrawal of care, I would have loved to give you some cases about probate court and conservatorship of the estates and of person, to see what has been going on in Connecticut, and have doctors been held liable, have conservators been held liable, where is this fear factor coming from, etc. But actually, all of these hearings are deemed private because they're of incapacitated patients, and they're not for public review. So I don't have any cases to review about, is there a situation where a doctor was, was sued for certain decisions that they've made? That is not for us to know. So probate court jurisdiction, approximately 25% of things they deal with is specifically directly related to conservatorship. When you add about the 9% that is over here for intellectual disabilities, that number gets even higher. In 2022 to 2023, probate court came out with their most latest report. There's been no report since then. But in that report, they said that in 2023, they had the highest number ever of conserved patients in Connecticut. They had 23,000 patients in Connecticut that were conserved under the probate court. That was 1,000 more than the year before, and that was a 50% increase since 2018. They also stated that compared to the US Census and the national average, Connecticut has an higher rates of patients with intellectual disabilities than the national average. So all in all, we have a lot of patients who are incapacitated in this state who require some level of decision-making, which is concerning. So conservatorship, not only are the numbers growing and the caseloads growing, but I'm worried about how expensive this also is. It's actually costing us approximately $8.2 million a year just for conservatorship alone. So this is all in thousands, which can be a little confusing, but the thousands are in thousands, so you multiply. This is how they decided to give their probate court reports. But it's 8.2 million when you add the attorney fees and conservator fees all put together. And as you can see, the trend in general, it is rising because the number of cases are rising. When a patient is conserved, if they don't have any financial means to actually pay for any of these things, the probate court covers all the cost. When they have financial means, then it comes out of their own assets. But about 42% of the 23,000 patients I had mentioned don't have any means of paying for it. So it's actually coming out of the probate court money. Probate court report also said that their caseload is incredibly high and they are struggling to find people willing to do such a big job for such little pay. So the next question people ask is, well, how much do conservators make? And one thing I've heard in the ICU all the time is, oh, I think this conservator is just doing it for the money. I think this is a money-making means to them. And I really want to know, really, how much do they make? So let's look at the frequently asked questions about conservatorship. How do you become a conservator? In order to become a conservator in Connecticut, sorry, I'm going to take a quick sip of water. All you have to do is submit an online form and do a 3-hour training. Most conservators in state of Connecticut are attorneys, approximately 90% of the time, and then some small portion, about 10%, are social workers. They are paid if they're through the court-appointed process. If they're family, they're not paid. They're paid approximately $52 an hour. And while that might seem a lot, as someone who's married to a lawyer, he tells me that's very little for a lawyer for an hourly rate. Then you break it down. The probate court specifically says you have to be billed at an increment of 6 minutes. So you as a physician, if you call a conservator and you have a 12-minute conversation about end of life, they get $10 for that conversation. They don't get $52 for the whole hour. So it's really not a lucrative thing. And that being said, no matter how much your caseload is, you only get paid for the time that you do anything for that patient. So it's not necessarily they get paid monthly for every case. Then I hear all the time, conservators tell us personally, I cannot make do not resuscitate decision without the probate court approval. So I wanted to find out what is within their means. And actually, there's only 3 things they cannot do without probate court approval. 1 is admit to a psychiatric facility. 2, do any invasive psychiatric therapies. And 3, change the primary residence of the patient. Those are the only 3 things. They most certainly can change code status and withdraw care. I think the concern that conservators have actually started from 2 judges ago. So in New Haven, 2 judges ago, probate judges ago, the judge had added an extra clause that said, you will not change, do not resuscitate code statuses without my approval. That was a while ago. And since then, that clause has been taken out. But I think that has started this concept that I cannot do this, I should not do this, I will be held liable. And so it's important when you're having these conversations to remind them that's not true. I don't know if you're going to change any minds of the conservator, but at least let them know that they're legally they are allowed to make these decisions. So conservatorship in the public eye. Lately, there has been a lot of issues with conservatorship. Most of these Hartford Current articles are actually related to conservatorship of estates, where thousands and thousands of dollars were stolen from conserved patients' accounts inappropriately. This third case, State Supreme Court holds lawyers and conservator accountable in probate case, is actually one of the only cases I can find that was related to conservatorship of the person. This was a gentleman who lived in Long Island, came to Waterbury to visit family, got ill, ended up in the Waterbury Hospital in the ICU, was deemed to not have decision-making capacity, as many of our ICU patients aren't, and got a court-appointed conservator involved because they could not find family for him. By the end of his hospitalization, he claims he was able to make decisions, and yet no one listened to him. He was put in a psychiatric facility against his will, had a very abusive roommate, and really fought to go back to Long Island. At one point, he even escaped to Long Island, and he was brought back to Waterbury via ambulance against his will. Families were eventually notified that this was happening and got involved and fought the probate court to get his rights back. And it was, in fact, he had capacity the whole time. And so he ended up suing. He attempted to sue the probate judge. He found that to be very hard. So then he sued the conservator that was taking care of him. But this was one of the only cases I found where we actually have some issues regarding that. And I think this adds to the concern to liability that many conservators have, where they just don't want to be sued for these cases. So I think there's a trend in recent times between the do not resuscitate clause that was added from a few years ago by a judge, and then some legal cases that have really made conservators very afraid to make decisions. So in recent times, at a national level, we've also realized this is becoming an issue and a trend across the country. So the national guardianship reform efforts have taken into place. In 2017, a federal law was passed that allowed for increased funding for state courts so they can do better monitoring, certifications, and training of their guardians, and to create programs within the state to detect, prevent, and address abuse. So I'm not saying there's never a time for court-appointed conservatorship. What I am saying is I don't think it's appropriate for that to be our first stop when a patient lacks capacity and is unable to make those decisions. The reason I say that is because what we've learned is that court-appointed conservators are often slow. For example, in order to even get a court-appointed conservator, the fastest path you have is something called ex parte. That can take up to 3 days to get. And in an ICU world, 3 days is an incredibly long time to wait for a court to get involved. It can be expensive, as we had just mentioned. Not only does it cost taxpayers millions of dollars, but if the person has finance, it actually costs their own personal finance, the amount of money it takes to get conserved. They're often unavailable. How many times have we called and you get the paralegal or you get the voicemail and your resident just keeps leaving voicemail day after day, just giving them updates, but really can't get through anybody. And then often they have presumed restriction. So we know they can make decisions, but they feel like they cannot, and so they won't make any decisions. And so my concern with Connecticut conservatorship is that if their default is going to be do everything, and if the answer is withdraw care, I have to go to the probate court, then I don't understand personally why we need a conservator in those situations. But I will say there are certain clinical situations where I found a court-appointed conservator to be appropriate. They are neutral. So there are cases where family is involved, but it's complex. They fight, they have differing opinions on what's correct, and you really cannot figure out who has the patient's best interest. In those specific decisions, I think it's important to get a court-appointed conservator, to get somebody who's neutral and who has a legally empowered backing to make those decisions. Lastly, there are patients who will continue to live a long time and will need long-term decision-making. They will go from home to hospital to a different long-term care facility. It would be nice for them to have somebody with continuity, and that's not going to be a physician or an institution. So one thing we talked a lot about legal laws, state laws. Let's talk about what is the policies here at Yale New Haven Hospital. So here, I'm sure you guys have heard of the conscientious practice policy. I want to specifically emphasize the conscientious practice policy is what you use when you have some type of surrogate decision maker. So whether that be somebody who already has a court-appointed conservator or a family member. And those who have a decision maker, they have conflict with what you think is correct. So if they're suggesting that you should do full code and you think it's inappropriate, that's when you reach for the conscientious practice policy. There's two different pathways. There's the 8-step pathway, which allows for more time and getting more different teams involved to decide what's appropriate here. Then there's the time pressure decision, which is what often we end up using in the ICU. And that's when you don't have time to get everyone involved. And you can say 2 physicians get involved, say this is inappropriate care, and you can change code status. This is the practice policy you should think of when you have a conservator who will not change their mind or is reaching out to probate court, but you just feel like you're continuing inappropriate care or the patient is imminently dying and you don't have time for that process to continue. You don't need to feel like you have to do chest compressions for that patient. You can use the conscientious practice policy and change the code status without the conservator approving it. So that's very important, and this is very recent in Yale policy guidelines, and I am very grateful that we have this to back us up as an institution. The other policy we talk about is treatment option policy. This one is pretty thorough. This is basically the umbrella policy. So it walks you through different scenarios. For example, if you have a patient with advanced directives, what do you do? If you have a patient with advanced directives, no advanced directives, but a loved one, what do you do? It's a great policy to go to in these complex situations. But this one you can also use if you have no surrogate decision maker. So conservators are not involved yet. They haven't been assigned. You can use this to then guide your decision making. So in the same way, you would also do 2 physicians if you think it's appropriate to withdraw care. But in this case, if you don't have a surrogate decision maker, you can use this policy. The other one is if you have a surrogate decision maker, but you don't agree with them. So now we have a mini JD. Let's go through some complex cases. So this first case, this is an 82-year-old with a large MCA stroke. And with that, she has very difficult time speaking. She's in the neuro ICU and she has difficulty in speaking. And so she requests a voluntary conservatorship. She wants to appoint her grandson for both conservator of person and estate. Family members raise concern that the grandson has secondary financial incentive. So what do you do? A, defer decisions to grandson because that's what the patient requested. B, defer decisions to patient given she has capacity. Or C, request voluntary conservatorship on behalf of the patient and emphasize concerns that the family members have expressed. So in this case, and once again, all the cases I will talk about are real cases. In this case, this is an example of a voluntary conservatorship. It is appropriate for her to want conservatorship. She's really struggling to communicate with us. So even though she has capacity, she has difficult time verbalizing it to us. So this is an example of a voluntary conservatorship. However, when we as a hospital petition the probate court for this conservatorship, we should emphasize that there are some concerns that the family members have raised around the financial incentives of their grandson. So during the probate hearing, this is exactly what we did as a hospital. We brought it up to the probate court that she would like to be voluntarily conserved. She wants her grandson, but there are these concerns. And so the probate court actually said, you know what, this seems inappropriate to put the grandson. We're going to do an independent court appointed attorney to handle the conservatorship of the person and estate. And which I think is appropriate in this case. So in the same situation, the patient with the stroke, she's deemed unsafe to return home due to her disabilities. We recommend an extended care facility and we call the conservator to ask for consent to do this. Can they consent to this? So yes and no. Technically, what did I say? The conservators can't do 3 things, of which one of them was you cannot change the primary residence of the patient. So technically, they cannot consent to this. But because there would be a lag in the whole process, probate court has allowed a specific hospital to a facility discharge to be allowed as long as the conservator files within 5 days to have the probate court review the process. But this is something for us to know, that there may be some barriers to discharge if there's some concerns regarding this. And so it's always important to tell the conservator in advance if you anticipate discharge to a different facility and you plan on changing their address. Okay, next patient. So we didn't talk about DDS, Department of Developmental Services, but it's very important that there is some caveat to their department that I wanted to emphasize with these cases. So 78-year-old with intellectual disability who's a ward of DDS, which means that basically they get services through DDS. He's in the ICU with mixed shock, intubated, multi-organ system failure, requiring escalating pressors. Prognosis is poor, and family at bedside all collectively agree that we should transition to do not resuscitate. What do you do? Switch code status to do not resuscitate, given unanimous agreement by family. Reach out to probate court to seek conservatorship. Reach out to DDS for review of case, or frantically call Dr. Honidan for guidance. I think D is always right when you're concerned, but in this case, the correct answer is DDS to review the case. So prior to this case, I empowered all of you guys to use the Removal of Life Support Act to make decisions for withdrawal of care, to feel comfort that there won't be any liability towards you. I encourage you to use the conscientious practice policy or the treatment option policy. I will just draw a big asterisk to all of that and say, except for patients that are wards of DDS. Those patients are seen as extra vulnerable. And so we should not change do not resuscitate code status without DDS approval. So that this is an example of that case. DDS specifically has a state legislation that says you shall not be implementing prior to review of by DDS. They're usually pretty quick, 1 to 2 days, they can get an expedited hearing and review the case. All right. So a similar DDS case, 82-year-old, this is a patient actually of mine that I had intellectual disabilities, had stroke, and due to that had dysphagia, had a peg placed, and had reoccurring pneumonias due to non-adherence to NPO status. This is his 3rd time coming into the ICU because he needs high flow nasal cannula, because he continues to pull out his peg tube and eat by mouth and aspirate. In your paperwork during admission, you realize somebody, the hospitalist, has already submitted paperwork to DDS for a DNR review, and it's been accepted. DDS agrees that that's appropriate if we wanted to pursue it. His family wants to take it one step further. They want to actually consider DNR and DNI and allow comfort feeds. So what do you do in that case? A, reach out to DDS to seek a DNI and comfort feeds, transition to comfort feeds in hospice as per wishes of his loved ones, or allow PO intake, but pursue intubation if necessary. So this is actually a case that we had over the weekend. Dr. Seiner was on the weekend. We consulted him on the side, and none of us knew what to do in this case. And the answer actually is DDS only does DNR review. Once they have deemed that it is appropriate to transition to DNR, they are basically allowing the loved ones to make all future decisions going forward. And so you do not need to get DDS involved again for a DNI code status or comfort feeds. Once you have the DNR approved, now it's like going back to the regular pathway where you would listen to the surrogate decision makers. So in this case, you can transition to DNI, to comfort feeds, and even hospice when you feel it to be necessary. So this is another case.
So that one is a that I get the DNR concern, but in terms of giving fees, like if you didn't have that, are you also obligated to withhold? Like you're not talking about withholding, you're talking about giving something a fee. Do you need permission to feed that patient, or is it really just about repeat the question?
Yeah, so I think your question, if I'm understanding correctly, is that actually I'm not. Can you repeat your question?
Why do you have to give permission to give usual care, which would be
Oh, I see what you mean. Yes. So why we have DDS review DNR, but do we need DDS to approve feedings and DNI, et cetera, prior to DNR approval? Is that the question? Okay. So yes, because if you withdraw feeds, then you're causing harm to the patient. And so in that case, if they're full code, then we should be doing everything that's best by the patient. So in this case, if they are allowed to eat by mouth, they're going to aspirate. We know that we have documented history of aspiration. That's inappropriate. We would feed them by PEG, but he keeps pulling his PEG tube out. But you would not allow oral nutrition in a patient that has known aspiration risk, who's full code, ideally. So this next case is a 71-year-old with advanced dementia who comes to your MICU and lacks capacity. In reviewing her chart, she has a conservator of person and estate by court appointed in 2023. When you look further into her chart, she actually has an advance directive from 2018 that puts her daughter as her healthcare proxy. You look at the conservator paperwork and it has no mention of the daughter who is the healthcare proxy. So who do you reach out to discuss patients' wishes and consent, assuming the daughter is around? The answer here is the healthcare proxy. So in the state of Connecticut, patient's healthcare proxy is gold, essentially. That trumps everything, including conservatorship by the probate court, unless the probate court specifically writes in their paperwork that they would like to negate that healthcare proxy. So if you ever come across a situation and there is a healthcare proxy and they're happy to be involved, you would call them. You would not call the conservator of the person, even though they're court-appointed conservator. This case happens rarely, but it does because sometimes people don't know there's a healthcare proxy, or they tried to call the healthcare proxy and they were unable to get through family. Family members come and go, and so it's important to know that. So court-appointed, in summary, court-appointed conservatorship is a growing proportion of our ICU population. And as I mentioned, it's actually, from a national level, we actually have a higher number than we do at a national level. So it continues to be a problem in the state of Connecticut. State laws vary significantly, and our state laws have a lot of ambiguity. There's delays, costs, and presumed restricted decision-making power. This creates a very frustrating situation, which I'm sure we've all been part of. Future directions, things I think we can improve on is, I think we need to increase advanced directive accessibility. And Ned Lamont already did this by allowing MOLST and PULSE, which if you're not familiar with it, it's a paperwork that anyone can access online. You just search it, print it, and fill it out. You can do it with your physician if you have questions, but it actually becomes legally backing. And so it allows for increased accessibility to do your advanced directives without having to pay attorney fees for those who cannot. I also think that there is room to have a statewide electronic records of advanced directives. So when a patient comes to us, then goes to Hartford Healthcare, then goes to St. Vincent's, and then goes to a facility, we as providers should have an online access to these records where we don't have to seek out the loved ones to see where this advanced directive lies. Lastly, I think the biggest thing Connecticut needs to do is we need clear and concise state laws to remove this concern of ambiguity. Us as physicians, there's so many of us in these frustrating situations who feel not empowered, feel confused on what is our rights, what are the patient's rights, and what are the surrogate decision makers' rights. And so I think it's important that if we have clear and concise state laws, and there's clearly a lot of room to change in Connecticut. As I had mentioned initially, I am by no means an expert in any of this. And so in order to put this talk together, I went to the experts. And so I want to thank Dr. Siegel, Dr. Tolchin, Jennifer Hurst, who's a professor at Quinnipiac Law who does specifically this, Dr. Haneden, Dr. Brito, and Canara Pagano, who's our associate counsel here at Yale Hospital, who they've all been tremendously helpful in helping me create a talk that is clear, concise, and also legally backed. Of course, I married into a family of lawyers, and I should have said that at the beginning. They don't do conservatorship, but my husband's family, they all do wills and estates, and so our boat is, of course, called probate. And this is our dog sinking in 20 feet water, and my husband trying to keep both of them afloat. All right, so I'm going to open it up for discussions for the last 10 minutes, and hopefully we have time for answers and questions.
Thank you so much, Vruksha. That was so expertly delivered, and I'm not ashamed to say that I got stumped on at least a couple of those questions. So thank you so much for educating us about this important topic. So we're open for discussion. Any questions from the audience? Here's Jake.
Great talk. Thank you so much. One question I had, so you mentioned the ambiguity of our state laws and like next of kin. Like, what are the implications for us as clinicians? So like the patient's middle brother is there and makes a decision and someone else disagrees with it. Like, is there a way that goes south for us, or like what is the best practice you'd recommend in a situation like that?
Yeah, and that's, I think, a perfect, oh yeah, the question was, oh, I think it's in the microphone, so I think it should be okay. I think in that case, and I have, Dr. Tolchin here to help me, to correct me if I'm incorrect, but in that case, I would go to the conscientious practice policy, and also our treatment options policy. Actually, both would be appropriate here. Treatment options policy gives us a hierarchical decision maker. The state does not, but our hospital has kind of created a hierarchical decision maker that allows us to know who to go to. In your situation, because we're doing something that's not legally, correct, I would get the conscientious practice policy involved, because there is a conflict, you're telling me, between different decision makers, and not everyone is in agreement on what is the correct thing to do. And so instead of making the decision based on the next of kin only, I would support yourself as a physician by going to the conscientious practice policy, getting numerous different interdisciplinary teams involved to see if there's a way to resolve it. And if not resolve it, be at least unified in our decision as a hospital. Would that be correct?
I think that's reasonable. I would first try to get consensus among all of the surrogate decision makers, right? So if you have a split within the family, I think the first thing I would do is a family meeting, and definitely the ethics consultation service is available to support that if that's helpful to you. There are other services like palliative care that can also be very helpful in facilitating a family meeting. And the best outcome is that you can get everybody on the same page and get to consensus around a pathway, a treatment pathway, whatever that treatment pathway is going to be. If there's a really irreconcilable difference among the surrogate decision makers, then you're going to look at, first, is there a healthcare representative documentation signed by the patient himself appointing one person, or another advance directive giving some guidance? That's very unusual that the advance directive is going to settle a split within the family. But sometimes a healthcare representative form will say, actually, this brother is who I want to make my decisions for me. In the absence of that, there is this hierarchy. It is commonly accepted in clinical practice in the state of Connecticut and nationally, and it goes spouse, adult child, parent, sibling. That hierarchy is in our treatment options policy, as Vruksha commented, and I think you're on pretty strong grounds using that hierarchy. So if there's a adult child says do X and the brother says do Y, you're pretty safe going with the adult child. If it's a split between siblings, that's more difficult. And then I think it would be reasonable to involve ethics perhaps to sort of, make a decision that we're going to go with this sibling over that sibling for the following reasons, based on the following clinical reasoning. And the conscientious practice policy might come into play there. The conscientious practice policy is particularly for withholding or withdrawing treatments. So depending on which way you're going, if you're providing a treatment, you might not use that particular policy, but the ethics consultation service could still be helpful in that case. Is that?
Hi.
Oh, there we go. So that was great. I was really struck by how common this is. I think we've all cared for patients, but the numbers at the very beginning of the talk, it suggested really, really common. And given how common this is in the ICU in particular, where patients during critical illness lose capacity, and how long it takes to get a conservator or something, even on expedited pathways. Did you come across a model where there is like an ICU temporary proxy medical like a hospital appointed cadre of people that can jump in that role while we're waiting. I thought I've seen some literature on that. I was wondering if you came across that.
Yeah, I think that's kind of similar to what New York does, but they break it down on, so for example, I haven't seen any state that does this for non-urgent decisions. So for example, they're not going to have a multidisciplinary team make a decision on routine care that can be provided. But I haven't seen anything where it's a dedicated person that makes those decisions for across the board for all ICU patients, if I think that's what you're asking. But I think what New York does, and actually many states do, is that it kind of breaks it down on what kind of decisions you're making, but keeps it within the institution. So to minimize the timing of a probate court. But yeah, I don't volunteer for that, but we should do that.
Hi, thank you so much for this talk. I learned so much. My question is for people that have written advanced directives or something written down, but no healthcare proxy, because I feel like we get that a lot in the ICU where they have something written down and then we do the implied proxy with their family member who says we're not going to do what they have written down.
Yeah.
So what do we do in situations like that?
That's a great question. I don't know the legal backing behind it, but I personally think that the appropriate thing would be to follow advanced directives. You can't be wrong on that, really, unless the family says something specifically that would change your mind. But advanced directives, at least from my understanding from what I learned in Connecticut, is that should be what should be followed, unless there's something else that the family is bringing forward that suggests we should negate the advanced directives. Dr. Tolchin, any thoughts? Sorry, I keep relying on you for.
So this is tricky. We get this question fairly frequently. I would agree with Vruksha that the advanced directives generally takes priority over what a surrogate is saying, but there are a lot of caveats to that. I've definitely had cases where surrogates, family members have said, well, my father, mother, whatever, didn't understand what they were signing and like has like a very actually like plausible explanation for that. And I will say that there are better and worse advanced directives. So first of all, it's not unreasonable to call the ethics consult service and that when you're having this kind of dilemma. And I would ask the surrogates why they think the advanced directive is not legitimate. Like what's their reasoning for that? Did the patient say something to them that makes them think that the patient actually had different views? Did they, sign it very quickly and, without reading through it? Like why are they saying that? And then I would read through the advanced directive, because there are advanced directives that are like, they're very obviously boilerplate and they have like no individualized, detail. And then there are advanced directives that really like hang together well. They're consistent, they're clear, they've been individualized. And I might give more credence in the latter situation to the advanced directive and less credence in the former situation, if that makes sense. But as a rule of thumb, an advanced directive does take priority over a surrogate decision maker.
All right, so we have a question from the audience, from one of our applicants, and then we're going to close with Mark. One of our applicants asks, so it's a question related to case number 1. And so Austin asks, it seems to him that if the court is able to give her a different independent conservatorship when she has already asked for her son to be the person in charge, it feels like it goes against her wishes in a way. And then thinking about how it relates to the 4th case, it sounds like when the probate court must negate her next of kin, or else the next of kin would still take priority.
Yeah, I think it's a little different because in the last case, you don't have anything to suggest that the healthcare proxy is doing anything inappropriate. It seems to be kind of accidental. You've got conservator person, but you had a healthcare proxy. In the first case, I think the court is trying to do what's in the patient's best interest. I wasn't there for that court case specifically, but it's always a discussion. We're not going to force anybody to have a conservator against their wishes that they're not accepting if they have capacity, but it's more of a conversation of, hey, there's these concerns. We rather you do a court-appointed conservator because there is going to minimize this concern that your loved ones all around you are voicing. So I think it was, none of these cases have hearings. And so we have a hospital representative there. We have the patients, families are aware, and they show up to these hearings, and the patient is invited too. So it's always a conversation. And I wasn't in that hearing, but I imagine the conversation went somewhere along those lines, and the patient probably agreed that that's probably for the best. Then we have, I think, one more question over there, or no? Oh.
Thanks first of all for getting our interview grand rounds off to such a phenomenal start. And for the applicants, this is just a taste of what we choose to share with us. One thing that occurred to me while you're talking about this is that the problem with the conservatorship system that we have is not necessarily inherent to the concept, it's actually inherent to the implementation. Right? The court takes forever, the conservator is not available, it's not really clear what their investment is all the time. And it's really think that rather than say that we shouldn't have a conservator, maybe to acknowledge that the problem we face is that these patients don't have representation. And just to give a take on this, I think that we take for granted that our ICU faculty are so conscientious about decisions that are being made. But in fact, I think the systems were put in place because these patients are kind of vulnerable. And maybe not everybody's as conscientious as the people we're used to dealing with them today. So the question is, should the answer be not to bypass the system, but to fix the system?
I agree, but I think with the number of incapacitated patients growing, I can't imagine a probate court getting this level of caseload and doing it with the quality that we would want. And I think that's what we're starting to see nowadays, is that the quality seems to be slipping. And that's why there's been reform at a national level. And I think a way to fix that quality issue is to offload the probate court and bring it back home to the hospitals. Because as you said, most of us don't go into this position to do inappropriate care. It's to do appropriate care. And so when our ethics are being kind of battled with what we're forced to do, it also does not feel good in that sense. So I think there has to be a balance. And I think bringing some of it back to the institution would be very helpful.
No way I'm leaving one of our fellows without asking this question. So go ahead, Julio.
Thanks. Great talk. I loved it. I think one thing that happens a lot when families bring the advance directives to us is that we encounter this nebulous concept of futility, which like does not have a medical definition.
Yeah.
But I've always kind of been curious if there is a legal definition, or like if it's actually a legal term of art that we need to like look out for, that we should be aware of, because we might be in trouble if we like go through with something, withdrawing care, and then actually, oh, this did not meet the legal definition of futility.
Yeah. And so you're absolutely right. There is not a legal utility. There is not, like for example, a death exam. We know you go through these steps and you can say this patient is now clinically has passed away. We don't have that concept for futility. There's not, you meet these metrics, you've, lost 3 organs. And so now it's futile. There is no definition of that. And so it really offloads onto the provider. The Connecticut Removal of Life Support Act has 2 different definitions of what we call terminal illness. It has one is terminal illness. Once again, it doesn't really define it fully, but it calls it terminal illness. And the other one is neurocognitive severe damage, essentially. And that requires a expert such as a neurologist to weigh in. But it breaks it down into those 2 criteria. But from my understanding, there's not a clear, concise definition.
Terminal state.
So terminal state under Connecticut state law is the end stages of an irreversible life-limiting illness requiring life support. So somebody who is dying but is not requiring like IV medications, intubation, artificial nutrition, stressors, they don't require any of that stuff. They're not yet in a terminal state according to, the formal definition under Connecticut state law. It's once you're on some form of life support, once you're requiring some form of life support, and you're in this irreversible end stage of a life-limiting illness. And that, honestly, that's a clinical judgment, right? So it's going to fall on the attending of record to make that assessment that this patient is in a terminal state. And so if you talk to us about invoking the treatment options policy, the conscientious practice policy, often one of the first things we'll say is, is this patient in a terminal state? Do you and a second attending physician feel comfortable attesting to that in a note in the electronic medical record? And that's where a lot of legal protections for the clinician kick in, if that makes sense.
Well, join me in applauding for Vruksha one more time. Thank you so much, Vruksha, for this outstanding talk. And thank you to all our applicants for joining us today. I hope you had a wonderful day, and please feel free to reach out. Thank you to all our faculty, our fellows, and our staff for making this day such a success. Thank you so much.